This combined spinal epidural. For which surgery it was introduced? Any idea?
No, sir.
It was introduced for obstetric and gynecology, mainly gynecology. For hysterectomy, when only epidural was given, invariably they have to wait for 15 to 20 minutes for the complete effect and full effect of the drug to come on. Because it spreads slowly, and then you have to reassess and make sure that adequate height has been achieved. So some of the surgeons were very impatient. So one fellow, Arlero, he thought of administering spinal subarachnoid block. And then first he introduced the toothy needle on space, threaded the catheter, and then the over space he immediately made a subarachnoid block and gave the drug. And then if extension is needed or prolongation of analgesia is needed, he used to inject the drug through the epidural. So that is how the technique was introduced. And so double interface technique was the first method was done for faster onset of block and the facility to prolong the duration of analgesia by epidural top of injections. Then the modifications that were done were classified into the technique of doing this. Instead of inserting the needle in two spaces, they started introducing the toothy needle in one space, and through the toothy needle itself, what we are now using as the kit which we are using, we introduce the second needle through the toothy needle and then puncture the dura and then give the drug in the subarachnoid space and then thread the catheter and position the patient and proceed with the surgery. Now this had one drawback that the onset of subarachnoid block was quite faster, and then when you take time to thread the catheter and then put the patient down, by the time the subarachnoid block may sometimes produce hypotension and bradycardia and all these things which are common to subarachnoid block. So people wanted to avoid this. So they wanted to give the subarachnoid block after threading the catheter. So somebody thought of identifying the epidural space with the toothy needle in particular space, say L3, L4, and then introduce a spinal 26 gauge spinal needle in the same space by the side of the toothy needle, and then I deliberately puncture the dura and then inject the but identify the free flow of CSF, reinsert the fillet and leave it in space. Then you thread the cannula, the catheter into the tubule, and then once you are satisfied with the placement of the epidural catheter, then you remove the fillet and then inject the drug as the last, and then remove both the needles. That is how the technique was modified to avoid injecting the subarachnoid dose first. So that was the technique of single interspace with two different needles, single interspace with a single through the needle, and the single interspace technique with single needle by the side of the patient. So this picture tells you all about this. This is the original method of identifying the epidural space with the epidural needle and then doing the subarachnoid block through the second needle. So here what he did was he threaded this catheter through the toothy needle, then did a puncture of the subarachnoid space. And here the disadvantage is you have to infiltrate into two locations, and patient discomfort was there because you are
Yes, sir. Now I'm able to see you, sir.
And
Now I'm able to see you.
no, but the screen was not visible.
Dr. Kyle, are you able to see the screen previously?
No, sir. No, sir.
In between, there was some disconnection from your side, sir.
Yes, sir.
Oh, is it better?
Yes, sir.
Yes,
It is
sir.
visible now.
Okay. So this is the technique currently used where you don't introduce the needle through the needle. It is introduced separately, and you just identify that you are in the subarachnoid space by removing the stellate and wait for the free flow of CSF. Thread the catheter, and then you can inject through the needle as a last, and then get the full effect of subarachnoid block also. Okay. So the modifications done with, so the second modification you can do is the equipment. Specialized package is available. Then the drug regimen. You can use a combination of local anesthetic and opioids, or give opioids alone first and then top up with the local anesthetic later on. And it can be done by the patient in sitting or lateral position. And this is the technique that I have been describing. So I'll just go through that. And the advantages of the modification are, since both the needles are inserted in the same space, the site of puncture needs to be infiltrated with local anesthetic only once. And epidural test dose may be administered without fear, as there is no possibility of the catheter entering the subarachnoid space. And the epidural catheter may be advanced without not being in a hasty manner. And spinal needle, because you are going to give the subarachnoid block only as a last injection, and the positioning of the patient and the resuscitations are also much easier, and it is cost effective. The disadvantages is there is an additional time required for the subarachnoid space to be identified with a separate needle, and sometimes inadvertent removal of the catheter has happened when you try to remove the needles, both the spinal needle and the 2V needle. And epidural catheter may be displaced when the spinal needle is being withdrawn. And the other modifications are sequential combined spinal epidural or epidural volume extension, where you give a smaller volume through the subarachnoid space and then give either saline or very dilute concentration of local anesthetic, which is supposed to compress the subarachnoid space and make the spread of the local anesthetic to a higher level and delay the onset of sympathetic block. And the other method we are now doing, especially in labor, is dural puncture epidural, where you intentionally make a dural perforation but do not use any drug intrathecally. No intrathecal administration is not done, and you do the epidural drug injection, which is supposed to slowly seep into the subarachnoid space and produce a very much more effective analgesia compared to the isolated epidural alone. So all the modifications are done for by individual practitioners to improve the safety and efficacy of the technique. That is the answer for modified combined spinal epidural. Okay, who is presenting the next?